can't sell it to anybody, but I think that nowadays we could offer a patient a little rotation of a tooth. Not the two centrals. The two centrals have to be always, and we know they have to be always symmetrical. They have to be mirror image. But once you start moving distally, that one has a little embrasure, a little bit more open than the other, it's okay. We have to know how to tell the patient that. We have older patients that will not take that, and they want that picket fence. And that is the patient that we're not going to photograph to put on our walls. Right? But our goal is always to refer to them almost like plastic surgeons, almost like artists, to say, you know, I think that if I show you a photo of a natural smile, will go a little bit better than if we just put white teeth on you. I think it would be a better idea. So she's got beautiful centrals, nice and prominent, and that's what I like to do on women, is to give them prominent centrals. And then the laterals give them nice and round. Okay? Did you see that effect? You missed that effect, doctor. Look at that. Okay, so PowerPoint didn't have that before. Yes?
I'm sorry. I have one that just like goes around the world.
Vortex? Yeah,
Sure.
it'll come up. So again, we see here the two prominent centrals. Okay, obviously natural teeth here. But something that we could do here would be just trim a little bit of this guy and bring it in a little bit if you wanted to. I mean, this and I know this, you know, it's a good idea. But I'm trying to show here how the laterals don't have to be identical. The architecture of that tissue has to do a lot with our case too. I have a case that I have to redo, as a matter of fact, here in San Diego. The patient came in to tell me that he didn't like the right side of his mouth because it was too long, and it was 6 teeth. And that's the most difficult thing to do in a smile, is 6 teeth, especially when we have really rotated teeth that we start hiding the buccal corridor. You know, so when we do 6 teeth, we really need to prep those those canines, especially the distal aspect of those canines, so we can see those premolars behind them. Well, this gentleman has really poor tissue contour. So his tissue on this lateral is about here. So this lateral is very tiny. We made it a little longer, but now we created an interference on the lower arch, and he already chipped the canine. That could be something that I have to look at, but that's something that the doctor has to check.
Right. I just had to redo I just finished a 6-unit anterior case that I did, and I had a number 8, the gingiva, because of the position of the tooth. You know, was shorter because of the gingival architecture. Well, I put it in there and it looked terrible, so I had to go back to a gingivectomy, redo both centrals to make it look right.
Yeah, and you know, with this gentleman, and I wish I had the case here, I don't think we picked it up yet. The doctor actually cemented the case, these 6 crowns, and the patient didn't like it. I really wish he hadn't cemented it and we could talk about it. He just went ahead, prepped it, and I didn't like the prep design. I like to be involved with the preparation when it comes to doing these anterior cases, but he just sent me the case, sent me a wax up that we did, the best that we could do, and then it just didn't fit in his mouth really well. So when it drooped, he just cemented it, chipped that canine, and everything looks really bad. And actually, he had an endo tooth of number 9, very thin veneer of number 8, so he feels a bump on the lingual of number 9, and he feels, you know, just like a little hole on number 8, it's just a little veneer. So everything is cemented. So what I told him, and I'm still waiting for the doctor to call me, I think in March sometime, I want to go to the dental office and re-prep the whole thing with him. First, because he's got the veneers already, recontour everything in the mouth. And just go on that lingual and just scoop it out. It's a dead tooth anyways, just scoop it so that now we have something that he feels better with. Fix that tissue. That's very, very important to fix that tissue to get a nice cosmetic case. And just shorten this whole side over here. So it's very important that we can start, you know, obviously seeing these patients that come in and you want to do a diagnostic wax-up, study that tissue architecture and study what we need to work on, what they want to get out of this case.